While the slides are being shared, I'd just like to offer a very warm welcome to Dr. Tazeem Bhatia, who is head of or Deputy Director in Nutrition and Science and Evidence in OHID, the Office for Health Improvement and Disparities in the Department of Health and Social Care. So I'm not going to say anything else because we want to get on. Thanks very much for coming, and we look forward to your presentation and questions afterwards.
Thank you. Welcome. Yes, of course. I'm sorry for the.
No, I'm no good with technology either.
Let's go for it. Yeah.
Oh, no, it's okay.
Where's the mouse?
No, it's okay.
mouse
Jen.
is
Possibly
Yeah,
on
but
the
I'm
big
just like,
screen, you
yeah,
need to bring it back onto this screen.
Can you do up and down?
This one is not working. Just minimize the images here. Oh, there it is. So we go.
Yes. Okay. Hopefully we're there. So thank you very much for inviting me to give this seminar on obesity prevention and the role of evidence in the policy cycle. Thanks for the introduction, Martin. So as I said, I'm Deputy Director of Nutrition Science and the Evidence function in diet and obesity and healthy behaviours in OHID. I'll give a little bit more description of what that means. I've been in this role in OHID in the Department of Health for the last year. My background is actually clinical. I was a GP. I then retrained in public health. And when I qualified as a consultant, I led Public Health England's global work on non-communicable disease. And with dietary risks and excess weight or obesity fast becoming the #1 global NCD risk factor, most of that global work, it was in the diet and obesity space. And that's how I sort of ended up here working, having worked on those sort of shared challenge and global market issues. There are many of you in this room who have a much longer experience in this space, both generating evidence and influencing policymakers. So while I can share my reflections of having done this role for the last year and what it's felt like and try to answer your questions, I do imagine there are many of you in the room who have thoughts, learnings, and challenges that would add a lot more to everything that I could say. So if I move on.
Your slide's supposed to be moving.
No.
Okay, cool.
Great. So a little bit about the structure. So in 2020, the government announced that Public Health England, which was then the National Public Health Agency, and its functions would be separated and that the agency would come to an end. All the health protection functions, they moved into UKHSA. The health care public health functions moved into NHS England, and the health improvement functions were moved into an office in the Department of Health and Social Care. The public health improvement functions were then brought together with the existing Department of Health policy teams, strengthening that sort of joint working between policy and public health evidence. And the Office of Health Improvement is led by a Director General and the Deputy Chief Medical Officer. So I've put up here a little bit of to give you a sort of sense of the Department of Health's remit. It's really supporting ministers with an objective to helping people to live more independent, healthier lives for longer. OHID then focuses on improving the nation's health through prevention so that everyone can expect to live more life in good health and tackling health inequalities. I'm then part of a directorate that is focused on diet and obesity and healthy behaviours. So it will do this, increasing health and life expectancy through improving diets and reducing excess calorie consumption and promoting physical activity. And then the function I'm responsible for is that nutrition science and evidence to support policymakers. So it's that robust assessment and translation.
Sorry to interrupt, but we can't see any slides.
No, we posted something in the chat. You can just
We're
bear with us and
working
say
on
we're
it.
working on it. Sorry.
I've only done 2
Thanks.
slides. Anyhow, they're not too complicated at the minute, so hopefully we'll
We're
get
getting
there.
there. There it is. Can you see it now?
Yep, thank you.
So for those of you who are less familiar with all the changes of the machinery of government, this slide is just to give you a sense of how that function has moved over the last 3 decades. So in the 1990s, you had COMA rather than SACN, and they said in math. Then there was a move into the food standard agencies in the early 2000s, where you had the creation of the Scientific Advisory Committee of Nutrition. You then had the start of the Dietary Nutrition Survey, which you'll be more familiar with its links to MRC, that went into the Department of Health at the end of the first decade in this millennia, and then a move into Public Health England, followed by now a move back into the department. So what am I going to cover in this session? I thought to really take you through the story as we would tell it to policymakers on them making a case for prevention and interventions, and where the evidence comes in and some of the challenges. So it'll be set out in terms of what's the problem, what are we trying to solve, what are the drivers, what works, and what is the impact. And that's the way that the story usually goes. We could probably have a long discussion on what is evidence. That's probably for another day. There are many forms of evidence of different strength and quality. I don't even touch on the hierarchy of evidence and how that compares with the medical model, another full-on discussion that I would say. But it's more about how we use the evidence to inform decision-making and balance that with the awareness that policymakers they're human beings, and they have a tendency, like all of us, to base their judgments on their beliefs and shortcut based on their emotions and familiarity with the information, and how do you navigate that, and what does it look like, feel like. And I think for sort of where we start, no matter whether you're from the left or the right, there's few that question that there is a problem. I think everybody accepts now that there really is an issue here, and you start to get into more discussion on what the drivers are, and you really get into a lot more challenging space when you move into what works and what is the impact. And so I will try to answer those questions, give a case study, and talk about some of the challenges and the gaps. So starting with what's the problem, there's nothing of this epidemiologically will be new to any of you in terms of the prevalence of adult and childhood obesity in the UK increasing. So for adult obesity, the prevalence has almost doubled in the last 2 decades as people move from overweight into obesity. And for children, if you took the Year 6 data from the National Child Measurement Programme, you can see that it's increased slowly over time. There's a huge inequality gap there. And you saw this significant rise over the pandemic period. Coming back to that point of significant inequalities, you really see the social gradient in children, where obesity prevalence for Year 6 pupils from the most deprived groups is double that of the least deprived ones, and that gap is growing. You have geographical variation, you can go into the ethnic variation that is not just explained by socioeconomic factors. We have to bring everything back to what's the implication of that excess weight and poor diet, and excess weight is a major risk factor for serious and chronic disease. So it doesn't escape any of you, but this is the story you would put to policymakers, that for type 2 diabetes, 80 to 85% of those with type 2 diabetes are overweight or obese, or 13 different types of cancer. Excess weight is the second biggest preventable cause of cancer after smoking. But there's also mechanical issues, the resulting musculoskeletal conditions, and with cardiovascular risk, the risk increases with the rising sort of BMI, and that's the sort of story you kind of tried to tell in terms of the impact that is having. Beyond the health conditions, it's very much an economic issue. These are estimates, but it gives you a sense of how big an economic issue. And translating the costs and benefits into monetary value has a lot of resonance across government. Economics is really the dominant narrative. These are estimates that being able to quantify the economic cost, the cost to the NHS, increasingly the cost to the labour market, which is a very big thing if you think about our post-Brexit kind of issues. This really helps to get decision makers interested to see, what the implications or impacts could be of doing something. So coming on to the diet drivers quite quickly, and I'm rushing over these because none of this is new information, it's just some of how we would tell the story. This is data from the NDNS, which you're probably very familiar with, that most people are not meeting dietary recommendations. We eat too much saturated fat, too many free sugars, not enough fiber, too much salt, and not enough fruit and vegetables. And that has been the case for many, many years. That is not new. And I think what's quite important is that with the rising trend in excess weight, we can't just explain it by the fact that we don't meet dietary recommendations. And if anything, for something like salt, things have actually improved a bit. So that's not where the answer lies on its own. And I think the rising, the case put is that the rising rates of overweight and obesity are caused actually by an excess in calorie consumption. We're just eating too much of everything. And if you go back, if you go back to the NDNS table, those are all proportions, so they're percentages of your energy intake or percentages of your fat intake. But on the whole, we're just consuming too much of it. These are estimates from Health Survey for England, because it's very difficult to get excess calorie consumption from something like the NDNS, which is dietary recall, and people underestimate how much they consume. You have to take the prevalence figures and actually work backwards. But for adults living with overweight and obesity, it's estimated that they consume 250 to 425 excess calories per day. And for children, that can range from 140 to 500. So 500, that's another meal that is being consumed. We have a wonderful seminal Foresight report from 2007, which really, captured well that, obesity is complex, multifactorial. But I think what it really did well to articulate, and this is a quote from it, is that while achieving and maintaining a calorie balance is a consequence of individual decisions about diet and activity, our environment, and particularly the availability of calorie-rich food, now makes it much harder for individuals to maintain healthier lifestyles. And so we've known that for quite a long time, and this is 2007. And when you monitor purchasing, so this is from the Department of, from DEFRA's Food and Family Food Surveys, you can just see the calorie-dense food purchasing is just going up and up over time. And the key issue is that the market rewards industry for selling us more and more calories than we need. And the environment has been evolved to drive that consumption. And again, not probably news to you, but if we think about how that obesogenic environment, as it's been coined, is evolving, and it is evolving fast, and sort of keeping on up to date with that is part of the challenge. The food we eat outside the home is estimated to contribute approximately a quarter of the adult calorie intake. But this will vary considerably across the population. That is the average estimate. Portions of the food that we eat out of home contain on average twice the calories as equivalent to in-home products. So as we eat more and more out of the home, to what extent is this driving our excess calorie consumption? We have had a big disruptor to the sector through delivery, which has really progressed through the pandemic. The delivery sector made up nearly half of the total value of the out-of-home sector in 2020. Increase in calories we get from takeaways peaked at more than double pre-COVID levels in the second lockdown. Now, these are specific COVID statistics, and there is a particular delivery story through COVID, but behaviours are not returning to pre-COVID levels. So it continues to be a disruptor. Also put up an icon of personal advertising. So nearly 50% of young people report seeing HFSS, so high fat, salt, sugar ads 2 to 4 times a day. And a third said that it makes them hungry or crave advertised products. Twice as many teenagers in the least affluent areas have been marked by Meta as interested in fast food, compared with those in the most affluent constituencies. That means they receive more adverts than their more affluent counterparts. And finally, the promotions, just thinking about promotions, we buy 40% of the higher sugar products are actually bought on promotion. And like promotions like buy one, get one free, they encourage us to spend 20% more than we would have otherwise. So we wouldn't, what that means is we probably wouldn't have bought that if it hadn't been on promotion. So that is the sort of evolving environment that is encouraging consumption. And the last thing to sort of say on this point is that, and just remind, is that we don't all experience the obesogenic environment in the same way. It's very different for my children who are in the more affluent versus in another area. And I think that bears out very well if you look at the normal distribution. So going back to the epidemiology, the dotted line or the dashed line, that's the baseline from 1990. And then on that you have NCMP data. And for the least deprived, rather, 10%, which is in green, you can see it's hardly shifted at all. It's shifted a little bit compared to 1990, but it's pretty much the same as when I was young. Whereas if you come from the most deprived, that normal distribution has completely shifted over. So what do we know about what works in primary prevention of obesity, and how do we set that out? Using the Nuffield balanced intervention ladder is the way we would set it out. So I think, as everyone knows, at the bottom of that ladder, you've got things like providing information, so government campaigns like Better Health or Change for Life. We've got the Better Health, Healthy Steps family program about to be launched, dietary advice through Eat Well. They would all be at that sort of providing information kind of level. Then enabling healthier choices through labeling, whether that's front of pack, out of home, alcohol calorie labeling, which we will hope to one day get in. And then you would guide choice through, first of all, changing maybe the default. That was the ambition of the voluntary reformulation programs, to shift the default. Or you could guide choice through incentives. So we have Healthy Start vouchers for the least well off that you could buy more fruit and veg with, or dairy, for example. Or you could look at things like health incentive pilots, like there's one happening in Wolverhampton. So they're the sort of easier ones at the bottom of the Nuffield ladder. You then go further up, guide choice through disincentives. I think modifying the cost of healthy or unhealthy foods, the CIDL is a very classic example of that. And then you can move into restricting choice, planning controls on restricting new hot food takeaways, and then restricting the influence of the less healthy choices. And a lot of the HFSS regulations that we're in the process of bringing in, so the promotions in terms of place has come in last October, but we've still got price promotions, still got advertising restrictions to bring in, and those sit in a far more difficult space and right at the top of this ladder. And as you move up the ladder, the political capital required to get that agreement, to get that implemented, that becomes more difficult, and therefore you need more evidence. Strength of the evidence required to make the case needs to be stronger. That's the bit I'm going to sort of move into. So just sort of comparing some of those policies on the ladder, something like and thinking about what we know works and what evidence we do actually have. If you take the CIDL, which was high up the ladder, we have got a lot of information around the impacts of the fact that it's worked, that you've seen sugar decrease, you've seen impacts on obesity prevalence. It's really well evaluated with a clear size of the impact. You take policies like the school fruit and veg scheme, we've got very little understanding of what impact that has on children's diets and how it changes things. It's not evaluated, and this is starting to become a problem in a resource constrained setting where everything is being questioned. The fact that you aren't able to demonstrate that is an issue, and what you're banking on is that it takes too much political capital to take it away, rather than actually on the strength of the evidence. This is a quote from Chris Whitty, who talks about what the role of academics are in this, and he often speaks to us about it being a triangle, and you've got to find the balance. So the cost and the possibility of the implementation, as that goes up, as the cost becomes harder, the strength of the evidence needs to be better, and the confidence in the impact and the effect of the size of the impact needs to go up. And so he talks about getting relevant science and research into policy is essential. Evidence-based policy ensures that the best interventions are effectively implemented. Integrating rigorous, relevant science into policy is therefore essential. But that starts to raise questions for us, doesn't it, in terms of, do we have relevant research? Is it sufficient? Is it strong enough? We can continue to produce more evidence to reduce that uncertainty or increase the certainty, but then how do you get it into policy? And policymakers tend to combine rational evidence, which again, we all know is never complete, so it'll always have its holes in it. And they combine that with irrational emotions of belief, habits, gut feelings. And it's that sort of mix in terms of trying to get it into policy that is the challenge. And I think the challenge for you as academics, but also the challenge for someone like myself who's in a position of translating the evidence into policy, it's that discomfort, or I think what's been called a sort of trade-off, with being a little bit manipulative about the evidence, using emotive language per se to get attention in the short term. And we've seen it, you know, some of the best and most effective actors do that. And we can talk about who could do that for you. And it's maintaining at least an image or a sense of objectivity to generate, you know, strong, credible relationships in government, so you can be trusted to be a reliable expert. And so the reality of getting evidence into policy is really not quite so simple as just producing more and more of it to reduce the uncertainty. This is just a quick sort of schematic of what the policy cycle looks like, and in your ideal, you've got ever strengthening evidence that feeds into all elements of the cycle. Sorry, that's but it's not a neat cycle, and it's just a sort of sense of that it's a massive spaghetti junction, really. It's complex, there are different actors, there are different ideas all being thrown around, you've got different institutions with rules, networks, and context. And if you're outside the system, I can imagine it's quite difficult to know where to influence. There's no single point. You have to compete with the other influences and their ideas. And then, you know, beyond government, there are, as a sort of try to, actually, it's on the next, for some reason it's come out, it's, oh, doesn't want me to go on. Oh, it's gonna, okay. It's going to come out in an animation that I didn't think we'd done. I'm sort of stuck. Oh, okay, no, it's catching up. Yeah.
The arrows, maybe? Oh, no.
Okay. So you've got all of these actors outside the system with different power and different influence. And if you're in the system, like myself, it's also really quite difficult to navigate through that noise, because there is so much noise and so much reactiveness. There's also a question of who to influence, who holds the levers. And it's, I mean, this is not news to you, but it's not just the Department of Health that would hold the levers for health, it's all the other government departments in terms of the wider determinants. And in addition, even if the Department of Health wanted to do something, it can't do it without the permission of other government departments. So you have to go through that process of what's called right round. They have to be given the opportunity to raise their concerns about what you want to do. And all those actors are influencing on all those other departments with whom you're having to then liaise. And convincing other departments, as you probably well know, whose objective is not health improvement and who are not judged on improving health as their outcome, that's the key, and that's quite that's again one of the challenges that lie is thinking about who needs influencing and where to get in. So it's not just health that you need to be speaking to. Another reflection would be that it takes time to learn the language of all these different institutions and networks. From my experience, I came from a national public health agency, been in there for a few years before moving into the department. We were an extension. I think everyone would see us just as an extension of government, arm's length body. But yet there has been so much to learn in terms of moving into government about how things work, the language that's used, what resonates, what will garner attention. And COVID also reminds us that crisis creates new context. So everything constantly shifts as well. It's not one. So I'm just going to give a quick example of what it's felt like, you know, feeding into the policy cycle around this policy, which is right at the top of the Nuffield ladder on restricting HFSS food marketing and advertising to children. So in terms of the agenda setting, right at the top, what brought it to bear, what brought it out as an idea. We had the Science and Advisory Committee Nutrition's report in 2015 was published on carbohydrates and health. That came out with high sugar intakes can lead to dental decay and to weight gain. We advised that free sugars should be reduced down to 5% of sugar intake or energy intake. And if you achieve this in the next 10 years, you'll prevent 4,100 premature deaths, this many dental caries, and you'd save the NHS £484 million each year by achieving the second recommendation. Public Health England then at the time brought out what would work. How could we reduce the population's consumption of sugar? They said no single action alone would be able to do it. You need to implement broad structured program or parallel measures to get a universal effect. And in that set, so just put out what the sort of key recommendations were for them. In there, you have the reduced opportunities to marketing and advertising. Now, we already had advertising restrictions on television since 2007, restricting advertising during children's programming. So why is it that we needed more advertising restrictions? So again, it was starting to make the sort of case that came out first in that report and ongoing from that despite having those restrictions, children were still exposed to a significant amount, and the studies were showing that affected how much they eat, both in the short and the long term. In September 2019, being able to demonstrate that almost half all food adverts that were shown on these channels were for HFSS products, and this rises nearly to 60% during 6 p.m. to 9 p.m. That sort of watershed, that family viewing time. And despite having these restrictions, the analysis was indicating that there were 2.9 billion HFSS TV impacts and 11 billion impressions to children on digital, online. Also noting the shift to online, that children spent more time online, now 20 minutes more than watching TV, and that we'd seen advertising spend online go up by 450%. So that was about sort of setting it out in terms of why did we need to do more. So you've got the Sugar Report 2015, you then got the Childhood Obesity Plan, actually Chapter 2, that announced the intention to consult on further restrictions. You got that reiterated in the Prevention Green Paper in 2019, but the opportunity only really came in 2020. In the Tackling Obesity Strategy, it was off the back of COVID, it was off the impacts related to excess weight and COVID outcomes. And then you got an announcement, an intention to implement. And in order to implement, the next pieces that you needed were an impact assessment and the support to the design of the policy as the bill went through Parliament. So in terms of getting the evidence for the impact assessment, from 2015 onwards, already you have got this collaboration between academics and government who started to work on the evidence of the potential size of the impact of a restriction. This systematic review and meta-analysis was quite key, and it's the data that went into the impact assessment, and it demonstrated exposure to approximately 4.4 minutes of TV food advertising would, on average, increase a child's food consumption by 60 kilocalories. And if you were a child living with overweight and obesity, you were consuming on average 46 more calories than those who were a healthy weight. And that's the data that went into calculating the impact assessment in terms of the impacts on health. There, in that you will also have the cost to business. At the same time, you've got a lot of evidence work that's going into the design of the policy. So this is the process that the policy will have taken through UK Parliament in order to get onto the legislation. But in order to design those restrictions, the restrictions include a list of products that are in scope of the legislation, and then you have to apply the nutrient profiling model, and the 2004-5 one was the one that was applied. So this is a two-step process. And a whole piece of modelling goes on to assess what the impact of such a restriction would be, how many products would be included, what would then be the cost of business of that. And then as you go through the process in Parliament and you have negotiations and you have amendments that are made to the bill, you've got to redo the work because obviously with amendments you can get quite a watering down of the legislation that you're hoping for, and the size of the impacts will change. It was great that the bill passed in 2022 and got royal assent, but actually if you look at the policy cycle, we're only up to the legislation part. We've hardly even made our way round, and now we're in the space of having to provide needing further evidence to support implementation and enforcement. We have in this period, as you well know, had several administration changes since that 2020 strategy and getting the bill to royal assent to where we are now. So with each one, you have to go through a period of convincing them that this is the right thing to do. And the question that you constantly get asked by each minister is, because you're asking them to use political capital to implement, is how do I know that what you're suggesting will have the impact that you say it will have on the problem? And that's where the further evidence base, again, is really important. So coming back to what was in the impact assessment, that's essentially modelling the results of the meta-analysis. It's as good as modelling is. You know, it was pretty good data going in. That's what we hope the size of the impact is going to be. But at the end of the day, it is only modelling. And to persuade policymakers, especially as you get to more sceptical policymakers, you need evidence of what's going to be the real world impact. It was been hugely useful that in 2019, Transport for London introduced restrictions on the outdoor advertising of HFSS foods and drinks across their network, and London School of Hygiene led on an evaluation that showed that there was an associated or estimated 1,000 kilocalorie decrease in average weekly household purchases of energy from HFSS products compared to if the policy hadn't been implemented. And then you sort of translate that into well, that equates to 143 kilocalories per household per day. And if that's 4, that would be 35 kilocalories per person or whatever. And you start to come up with, you know, you take modeling well into it much further than it is. I think what was key as well in there is that the purchasing, 20% of that reduced purchasing was from chocolate and confectionery, you know, a real area and links up with the other policies in terms of what you're trying to reduce. Bristol Council has also announced similar restrictions in 2019. No, I think it was 2021. Sorry, I got my notes wrong. And that is being evaluated. But while this gives us this period to build the evidence base to support the implementation and persuade policymakers, we've also got to recognize that you have similar efforts being made to dissuade policymakers. So the investment bank, Berenberg, said that the delay of 1 year to these restrictions could be worth an extra £100 million to ITV, with similar benefits to other UK commercial broadcasters, including satellite and cable, as well as Channel 4 and 5. You've also got papers being published now that challenge the methodology that the London School of Hygiene took, and they're being used to influence local councillors where other areas are thinking to bring in the same restrictions and really build up that evidence base. And I think finally, the other sort of gaps that we have is that we know we're going to have problems with the monitoring and the enforcement of digital, and the work to try to, you know, to set out what could work in that space is absolutely critical. And at the same time, for all of these policies, you have a post-implementation review, which you have 5 years to do, and that's the commissioning of the evaluation that also is happening or needs to happen and be linked to the date of implementation. So just in summary, I covered what works. Evidence demonstrates an increasing prevalence and costs socioeconomically as well, and that's not really disputed. Doesn't matter whether you're from the left or right, everyone kind of accepts that that is the case. In terms of the drivers, again, there's little dispute that one of the key drivers for increasing prevalence is excess calorie consumption. Things like our genetics and things have shifted completely, although they have, of course, have a role to play. In terms of what works, I think there is some clarity around needing a suite of interventions. There is no single action. There is no one bullet. You need a mix of nudges that change behavior, as well as changes also to the food environment that in there, and that's expanded. And I didn't even talk about new treatments, which of course came online, but they're not really part of primary prevention, but they are going to have a massive impact on turning the tide. And they definitely, you know, they do work. The trials are at least able to demonstrate that. In terms of the impact and the size of the impact and the challenges there, coming back to some policies have more evidence about them in terms of the size of the impact and how much that they can achieve. The more political capital you require, the stronger the evidence base. You also have challenges which we haven't really touched on, like policy incoherence. You implement one thing from one government department and a policy and another one completely just undermines it. And the classic example always is eating out to help out in COVID, which was just so blatant at the same time of bringing out a new obesity strategy. You're also impacting on systems. And I know you do a lot of system research, but you know, implementing all these piecemeal interventions you're implementing in a system, and all the consequences of that, intended and unintended, need to be considered, and who holds the policy levers. Again, it's not one government department. So if you want a suite of interventions, you've got to work with a number of government departments to get there and to do it. And so in conclusion, there are different types of evidence required across the policy cycle, different strengths, qualities to them. Is really, as tried to show in the case study, it's really important to be thinking ahead as to what is needed and how it might be challenged. That's not the responsibility of one actor. That's more effective when it's done in collaboration. So that working together in terms of different strengths. Policies higher up the ladder need stronger evidence, less uncertainty. Academics, public health professionals like myself, we've got a really important role in reducing that uncertainty through the generation and use of evidence. But getting evidence into policy also needs us to think about how do we link those findings to policymaker interests and concerns. And that comes back to that sort of tension with not being too manipulative, but persuasive at the sort of same time. I like these two quotes, and I think you've had Peter Gurney come and speak to you before, that too many studies assume that better dissemination will prompt policymakers to think like scientists, and that the scientific evidence alone is persuasive or self-evident. And that you need to remind ourselves that the political system is based on value judgments, and need to recognize that the production of evidence in itself is inherently value-driven as well. We like to consider ourselves as objective or neutral, but are we? And we surround ourselves quite often by like-minded people who have similar values to ourselves. And that's true in academia as it is in public health, or even any other area. And it's only when you have to start convincing someone who is a skeptic, and I can tell you over the last year that has definitely been the case, that you really start to test the strength of the evidence base against that. So thank you very much, and sorry to have rushed and run late now.
Brilliant. Thanks, Tazeem. That was excellent. Let's dive straight into questions. Does anyone have a question? You'll have to tell me if there are people online.
Yeah.
Okay, so we have two hands. Sorry, I don't know your name.
Thank you. Hello, lovely to meet you. Thank you so much for coming. As academics, I think I haven't really given a lot of thought to impact upon policy. How would you suggest that we learn to do that better?
So I would give it some thought to start there. And I suppose it depends on what your research is, and if it is very significant, if it's significant for policy, then that's the audience that obviously you want to have an impact to. That's not necessarily the case for everyone. So it is understanding who is your audience. But in terms of your question, I think, yeah, so it probably is difficult to measure, isn't it? What is the impact that you have on policy? But you could probably start to garner some sense in terms of the influence that you have on those policy discussions. And I think there's a lot to, I didn't bring it up, but it's recognizing the long-term investment that is required in order to get there. So one piece is not going to do it, attending one round table is not going to do it. And it's that investment and that long-term engagement. There are also structures within the system that are also sort of long-term, whether it's through NIHR. We talked this morning with Jean and Martin and Tom and I were talking about the policy research units and the academics, the input to that, the different sort of platforms to support that investment. But yeah, in terms of measuring your impact, I think, yeah, you've got to come up with some creative solutions for that.
Do you want to go online first? Because I can ask my question afterwards.
Yeah, sure. So there are a couple of questions here. I think one straight for our references available for the children's viewing percent of HFSS ad. Figures referenced in the presentation.
Yes, probably before we circulate the slides, I probably need to do a bit of tidied up of my notes, because what you want in the notes are the sources.
Yeah.
But you don't want all my spiel.
Yeah. Well, yeah, well, do that.
So yeah, we can circulate
so
that.
we'll provide those references. And then the second question from Jovita Leon. To what extent do these interventions regulations cover online food delivery platforms? These apps that increase, etc.
Yes, and that is in the notes of the presentation. So the online restrictions, first of all, they only cover paid for advertising. So they don't call it what's product placement that's not paid for example, through influencers or whatever, that's not covered. What is also not covered is a company's own website. They are still allowed to do what they want. So there's a restriction, and I think the biggest restriction though really comes from the fact that it is a product-based piece of legislation. So in order to restrict it, you need to be promoting a product. So that means you can promote your brand through paid for advertising, so long as there is not a product that is covered by the restriction in it.
So if a company, a fast food company, I won't name any,
Yeah.
Has a way of attracting children through perhaps some kind of advert game, some kind of gaming, which pushes children to their website. There's nothing you can do about that.
There's nothing you can do about that.
So it's a limitation.
It's an absolute limitation. And I think that was also quite interesting to see from the Transport for London evaluation, that what undermined the impact for them was the fact that there was a move, the displacement was to brand advertising. And so you still got, you minimized on the impact as a result of it.
Yeah, but I think we saw that from 2007
as well.
So it's kind of long-term trend. I mean, that's interesting because that presents challenges just for us as evaluators and researchers, because we have to think through what are the potential unintended consequences and work out how we can measure things like companies pushing to their website and so on as an unintended consequence.
Yeah, so measuring that displacement is absolutely key. I mean, I was speaking to Steve earlier on Friday, understanding also that displacement in terms of revenue generation, because you will get that displacement. And so these calls to say that the loss of revenue will be this is based on a sort of the system being quite fixed. And we know that we will get a lot of movement.
Yeah, I think that's interesting too. In our evaluation of the soft drinks industry, I think there were a lot of industry claims at the start when it was announced about loss of revenue and all these kinds of things. And I think through conducting a macroeconomic analysis, we've been able to show that actually the damage to industry is not as bad as was initially estimated. Other questions in the room? Mike, just say who you are.
Mike Kessler, I'm a postdoctoral research associate. Thank you for the presentation. I thought you explained really well the complexities of the problem itself and the complexities of the sort of political landscape. I was just curious your reaction to a point that I think there are those political complexities, but there probably could be even more attention paid to the complexity of the problem itself, which is obesity as a complex problem. And when we think about interventions being effective, we almost want to think about interventions not just being collectively, individually effective, but mutually reinforcing. And so this piecemeal approach seems to be quite a challenge to that. And so I guess I'm wondering, what do you think about sort of the necessity of having that suite of policies enacted together and then evaluated in the example of, say, like Chile, in South America or something like that, because there's so many more knock-on effects that can come from the suite of policies that are mutually reinforcing. So I'm working on calorie labeling, and just to implement calorie labeling in sort of its own context, you say, well, does calorie labeling work? It is a little bit of a mistaken question, because there's so many other ways that calorie labeling might work in the context of sort of a better comprehensive set. I guess, what are your thoughts on that?
I completely agree with you that, and what Chile have done has been fabulous in that way, is to comprehensively act. For all of us who then want to disaggregate as to what had what effect, it then becomes a problem, because of course everything is implemented together. But I completely get it. It's more than the sum of its parts. You've got to bring in together. And what I was trying to illustrate in the case study is how difficult that is.
It's really hard.
So you can put it all into one strategy at the beginning to say, look, we're gonna act, and we're gonna do this, this, and this, and this. And then it all comes in a piecemeal effect. So initially, when the post-implementation review was being designed in the first instance, the hope was, could you design it so it looked at all of them together? You know, you bring in calorie labeling and menus, you bring in promotions, or at least looking at the promotion restrictions with the advertising restrictions, so they're in a similar space. Can't now, because the whole thing's unraveled over time. So while I completely agree with you, because without doing it as a suite, you're basically undermining, because one's not going to do it on its own, and you then create the story that these interventions are ineffective. So I don't have a solution, but I do agree with you.
Yeah, there's quite a lot of pros and cons. I mean, from our point of view, having them spread out makes it slightly easier to evaluate them individually.
Yes.
But the problem is that we know that the system reacts to each intervention. So context in which the next one is introduced is different from the original context. And that's part of the problems we have.
And that's part of the problem that I have with the credibility with policymakers, because you'll have the modelling in terms of what individual one might achieve. And of course, that's based on the quality of the evidence that you put into the model, but you know it's a system. So you know it won't quite impact that, because we give quite a lot of time, and you have to get the legislation in. That gives the space to find a way around it. So then you don't have the impact you have, and you then lose the credibility which you set out saying this will achieve what it will achieve.
And I think there's things like, for example, the SDIL, our instinct is that it has led to more marketing as a compensation for reduction of sales.
Right.
Sugars with beverages, which then makes the ad ban even more
important.
Yeah, more important, but also more challenging as well,
Yeah.
because you've got new stuff in the online space that just exists before. It's more difficult to legislate.
And the personalised nature of the online space is a dimension we've just not got round.
There's a few more questions up here. Let's see if we can get through them quickly. Kate O'Hara, who's, I believe, a sociologist, asking about the ladder of interventions, the Nuffield ladder. Strikes me that the lower the intervention on the ladder, the less likely the intervention is to reach those who are subject to systemic disadvantage because of other competing factors, like the attacks on personal choice levied by aggressive advertising. Can we lever social justice somehow to push the impact further up that ladder? Which is quite a tricky question, I think.
It depends where you are societally. I think it's whether you can lever the social justice argument societally, because, you know, at the end of the day, government represents society and that societal view. I'm not sure completely that the ones at the bottom of the ladder don't reach people with disadvantage, but I think if you don't address the systemic structural issues with that, they're not going to resonate, they're not going to work. Probably being my interpretation.
From Claudia Soylent Reyes, who asks, well, in recent years, research has been required to include the views of members of the patients and the public. In your experience, what the impact of involving patients and the public in policy approval, and what's the best stage in the design process through to implementation process to do so?
I think that's a really interesting question, because I think one we ought to explore how it could be better done. So I think there's a lot of pressure that's put on academics and those contracts about getting that public participation into your academic process.
Yeah.
You then have these very formal consultations in a policy legislative process, which I think if somebody probably was to do a review of those, they wouldn't be a very broad representation of public opinion in those consultations, but more
That's certainly our impression from looking at the responses.
vested interest in those consultations. And I think there is probably a huge space for that, but yet we don't have the capacity or the investment in the policy process to actually have that voice better heard. And at the end of the day, ministers, they have a constituency.
Yeah.
And they're responsive to a constituency, so that would have traction and that would have impact.
There's a question from Simon Griffin. Simon's one of the professors of general practice here and also has a programme in this unit. Why do we need a similar level of evidence to support policies? It's very unlikely to cause harm, could easily be reversed if harm is demonstrated, as we do for interventions such as medications. So it's about the demands made on the evidence for different types of intervention.
I suppose you've got to think about causing harm to whom. So we're thinking about it here from, it's not going to cause a harm in terms of public health outcomes, but the problem is it causes a harm in terms of economic outcomes, or that is the way it is perceived.
Yeah.
And that's what you're trying to have to demonstrate with the evidence, is that you are minimizing the economic harm, or the balance is so swayed in terms of the health outcomes.
And you said earlier, economics is the dominant narrative.
It's the dominant narrative. It's how cost effectiveness is how decisions are made.
Yeah. Any other questions in the room? Ken?
Hi.
Hi, Ken.
From second.
Yes.
My program here, I guess, is more etiological, so I'm more familiar with, I guess, the first two steps in terms of what is the problem and what are the drivers. In terms of addressing the next two, sort of what works and the impact, I mean, I see after the carbohydrate report from second, I mean, the key next work was the sugar reduction, which was primarily driven by PHE. So how much, after generating that, do we, I guess, need to dialogue or know what the likely direction is, rather than just going ahead with ourselves and thinking, oh, this this might be a way forwards.
Thanks for the question, Ken. I think being a key member of SACN, I think you're sort of quite aware of some of the sort of changes in terms of the structures and the landscapes. I totally agree with you that that synthesis of what works, how do you get those dietary recommendations actually, how do you achieve them through interventions, is a really key step. And we have somewhat, publicly at least, there is a bit of a gap there that needs filling with the sort of change in structures, and we probably need to look at ways between us to fill that gap while it exists. I think it would be great if it came from a national level and it came from an affiliated government body in terms of setting out, but that's not the place that we're in at the minute. And it's how do you do that and use what the structures that you have essentially to influence.
Great, thanks. Great, thanks, Jodie.
Jodie Huning, Research Associate here. You mentioned that some policies have been evaluated a lot more than others. I was wondering if you can tell us on why you think some have been evaluated more than others.
So I think it firstly comes into the investment that we make in terms of requiring. So where you feel that something requires a lot of evidence to get it through, you've already started to invest quite heavily into that policy area and just demonstrating. Something like the CIDL, where it was quite seminal and you brought bits of government together with the NIH, so our structure, that post-implementation review, you got evaluations through that, but you got other evaluations. So other academics were able to use the NIHR system, recognizing the importance of demonstrating the impact of such an intervention that was at the top of the ladder for the UK, but also for other countries, and sort of adding to that. So it's sort of understanding, isn't it, which ones need more. And I can only imagine, and this is an assumption, it's not an evidence-based answer, that on the ones like school fruit and veg scheme, it's just there hasn't been a requirement for government, so they haven't asked for it. And no one else then within the system has seen that as a potential need or a gap. We might get to a point where you actually have a government who's so resource constrained that they think to take it away, and I think then you will start to see that come into play. And we definitely inside are sort of thinking about how can we get a bit more research on that and be prepared for that situation and actually improve it as well. You want a quality improvement process on your intervention, and demonstrate where it is having traction and not.
Yeah, can I ask one Oh, I've got one more here. Sorry, I was just going to ask my own question.
Well, I think
Wait.
that's a value.
Why is economic harm more important than health and wellbeing of the population?
I think for us sitting in the room, it's quite obvious what the answer is, but unfortunately, if you are held to account for growing the economy, you might feel differently about that.
What I was going to ask was about framing policy. Some evidence suggests that George Osborne and David Cameron, when the SDIL was being discussed behind closed doors in the early stages, that there were appeals to them from NGOs and others about the health of their children. So that it was framed.
That middle class voice.
Yeah, exactly. It became a kind of personal issue for them. Oh
Yeah.
my God, we've got kids and they're consuming Coke and all this sort of things. They're consuming fizzy drinks and so on. And you know, there's anecdote that this was persuasive. Do you think that that kind of framing is powerful or should be used more in relation to these kind of policies?
Yes, I
mean,
don't even think of
directly
it.
with MPs.
I don't even think it is completely framing. It is actually thinking about what's going to resonate as a parent who has children, who has that kind of concern. And even thinking about what gave those NGOs or civil society that much of influence or traction. It was a series of campaigns. I mean, I would think that Change for Life and all of those things, inputting and influencing and creating that attention on sugar that was happening that sort of galvanized it. And then it was taking it to that next step of how do I link it to that policymaker where they can see it has a reality for them. And so as we have a them and we create more of a them and us, and that social gradient, it's really destructive because it doesn't impact directly on those who are making the decisions, and trying to find those points to hook it or frame it or but it is really important. And there's a lot of work that's gone on recently about framing it to the libertarian argument. How do you use that? So that I think there are many, and some who probably worked in this unit who have spent time to develop that.
Yeah, we have someone's PhD on that at the moment. Great. Well, listen, we kept you going for a full hour despite the
Technological hitch.
challenge in the beginning. And so thank you very much indeed for a great talk and great answers to the questions.